There we go. Yeah, welcome everybody to our webinar session today. It's about fetal cardiac imaging using MRI. And this is the first session of our series in 2025. It's our spring session. Great to have you here. As a short note that this webinar will be recorded, as all the others have also been recorded, so you can later on watch all our webinars online. You'll find them on our website. And it's again me, Heide, and Fabian, both from Northh Medical, that will guide you through this session today. And yeah, every time I will emphasize this because I think it's of high importance. That's our aim, to build a community and to offer a platform for networking and exchange with this webinar. Because as this is still an innovative technique, we believe it's of very high importance that we learn from each others. And now we have already more than 90 SmartSync devices in the market. So there are already many sites and hospitals that are doing fetal cardiac MRI with Doppler ultrasound. So we have a lot of knowledge together now that we can share, which is great. Yes, we want you to participate if you want in this webinar. So everybody of you can talk with us. You can discuss. Please raise your finger, and that shows us that you want to speak. And you can also paste your questions directly into the chat, or you can use the Q&A function. So this would be great that we have a discussion and all your questions can be answered today. So there's a new publication online, it's brand new, that I would love to share with you. It's a multi-center study where 3 sites have participated. It's one from University Hospital Bonn. The other site was Children's Hospital Colorado and Phoenix Children's Hospital. And there have been 98 participants that have been analyzed. And this publication shows very nicely factors that influence the image quality in fetal CMR. And yeah, I'm very sure that this will help all of you, this information and this insight. That's why I wanted to share this information with you. You find it online with the title. If you can't find it, send me a short email. I send you the PDF. So the title today is for our spring session. It's the evolution of fetal cardiac MRI. We will show global developments and technical insights. And before we start, I would like to start with a very quick poll, because we believe that it's of high interest to get some information from you. And now you wait a second. If you have experiences with fetal cardiac MRI scans already. And I think now I'm starting it. And you should just type in your answer.
"21 responses. 26.
Oh, wait a minute. I think I did it. I did it wrong.
Yeah. Yeah.
Funny.
Yes. It's interesting.
Okay.
Just wait a little bit more.
We give you a few more seconds to see your responses. I think it's very interesting for us also to lead the webinar a little bit into that direction of your experiences. So I think that's it.
Yeah. Thumbs up.
Okay, there are about 30% that have not yet any experience with fetal cardiac MRI. And then there are about each 20% who have a lot, or they have just scanned some cases. Yeah, most of the participants have scanned some cases. And there are about 20% that have just started to do fetal cardiac MRI. That's great. Okay, good to know. Okay.
Stop. Maybe.
Wait. All right. All right. Oh, sorry. I wanted to share one more. Yeah, I wanted to share one more poll with you. Does that work?
Yeah, I think so, yeah. If I answer, then it's probably
But
not
can you see the
good.
relay?
Yeah.
Okay, great. So the question is, do you use fetal cardiac MRI as clinical service in your hospital? I think this is a very important information. And we also go in detail regarding that later in our webinar. And here the answer from 43% is yes. About 30% say no, and only research are about 25%. Okay. I give you a few more seconds. Has just slightly changed.
That's interesting.
Okay, thank you for your participation.
There are more coming.
Okay.
It's already 40%. Interesting.
That's a lot, actually.
Good.
All right.
It's better than none.
To continue, we have 3 experts today, and the first one will be Fabian. He will give you a short introduction into also the whole path of Northh Medical, how everything, the SmartSync device and everything has developed, and where are we now, the status, and also to take a look into the future. And with that, I would like to already hand over to Fabian.
Do you open the slides on your PC? Oh, okay. So I hope you can see the slides. So the idea was to talk about a little bit where are we now and where do we want to go. So to know that, we thought, okay, we look a little bit back. This is now 10 years ago that we started in Hamburg, and people asked us, hey, can you do fetal cardiac MRI? And we were quite young. We said, yeah, sure, why not? Somehow we can do that. We had actually no idea. So we started to build something as a first prototype, and you look like this. It was actually never working, but it looked fine. And then from that, we built a first prototype and a second prototype, which were looking like this is how I show that. So it was very, very researchy, and we were trying to do something that works, but it was very, very tricky to develop something. And it was from 2016 to 2017. And if you look on the left, that was how it actually looked like in the lab. And on the right, you see this this wide triangle first prototype. This was in 2018 with the first very early publications we have done. And here we have worked with Boston Children's Hospital and with our colleagues in Lund and in Hamburg, of course, to somehow get the first results. And only in 2021, we developed SmartSync as you know it now. So this is where we actually got our CE approval. And if we look into this now of this entire journey, how we started in 2015 with basically nothing, we are quite happy that we have a team of 15 or 16 people now, which includes the majority actually in research and development, but also marketing and sales with high clinical affairs, and a lot of students. So this is quite fun. And we all share the vision of that we want to enable a new clinical pathway for prenatal imaging. And we were all quite happy that in 2023, we found a publication from Desmond et al. Actually sharing the exact same vision, that if the screening with ultrasound and the fetal echo is unclear with unclear findings, that we can add the MRI now for an improved neonatal outcome, and where we have a better delivery location, the mode of birth, know about the NICU admission, where also the idea of an immediate neonatal procedure or surgery can be planned better. And yeah, this is something that I think we all share as a vision. And if we look at the installed base of the devices we have in the market now, from 2020, that was starting with 5. I think these were the very, very early prototypes. In 2020 and 21, we got the MDR clearance. Then 1 year later, the FDA clearance. Then we started with Israel, Canada, and this year we actually go to Taiwan, Singapore, Chile, Turkey, and Japan. We almost have 100 devices in the market now, with a majority in the US and Europe. So Europe is a little bit bigger, I think, like with 46 compared to the US, but we are also 1 year ahead. And 15 devices in different countries. I think there's, this is something like Israel, this is something like China, but also Japan. And this just shows that the entire community is growing and growing. And then I thought, okay, it's growing. So we have our friend ChatGPT. So I asked ChatGPT, can you please tell me something about the development of fetal cardiac MRI from the 80s to today? And it was quite fun what the response was. It was, okay, in the 80s, of course, MRI was in its infancy, and there was actually nothing from MR, and fetal echo is, of course, the primary tool. And starting from 2000, there were the first studies for fetal cardiac MRI, but very limited, because the MRI didn't have the resolution, and there was no gating and no motion compensation strategies. Afterwards, with the metric optimized gating and also Doppler ultrasound gating, it was fun that actually ChatGPT found that, so I was quite impressed by that. This has changed, and now from the 2020s, it is from the knowledge from ChatGPT in the integration into clinical practice. And we see on the bottom right how the increase of publication actually is very impressive in this kind of field. So it seems like there's a lot of things moving. So where are we now from our perspective? So without artificial intelligence. And for us, it would be really interesting to know what you think where this application is. So from our perspective, we have the phase of basic research and concept development. We have the phase of clinical use and research, and afterwards the clinical standard where most of the things is done. And I don't know, Heide has prepared a different poll where we would like to see where you think in what kind of stage we actually are.
Right. And we will start that one right now. So we, no, what do you? Oh no, I don't have this poll. Sorry, I just have it.
Okay, then we don't do that.
We cannot do that. Sorry.
Okay, then we don't have that. We'll find this. Okay, here. So we will never know your answer. Thanks to Heide.
Maybe I quickly do.
No problems. So of course we got that stage done, and today we think we are in the stage of the first clinical use and research. And when I see the first results we have done, this is actually something what you are also in. And right now we gain experience for the clinical use and its application. And the question is how we as Northh Medical actually can support that kind of stage. And in the last year, we have done a lot of work in application support with Domenico as a clinical cardiac specialist, who has done a lot of online support and a lot of also on-site visits to enhance MR sequences, to enhance image quality. We have guidelines on our website now and training materials that help everyone for for better application, and we plan to have a better remote support. We want to also improve SmartSync for the better reliability for the signal during fetal motion. And we need to improve our algorithm for easier detection of the fetal heart. Another very, very important thing is to build a community, as we do this with our webinar here, for exchange and transfer the knowledge between sites, between clinicians. Here we have our webinar like this, of course, but I think also conferences and workshops are very much key to build this community. And we are very keen to do that, and we want to support that. And we understand this a little bit as well as our mission to help everyone to be connected. So we're not 100% clear how we can do that, but we try to do that all the time. So if we can do that better, and if you have ideas what we should do to build this community, please reach out to us, because we are also new to all of this, and we want to build this. So it's very important for us to learn how to do it in the best. And then at the end, we of course want to establish this as a clinical standard. And we think there are a couple of challenges to solve, which is, of course, reimbursement. It is a guideline for fetal CMR that is not published somewhere. So in which cases does it bring the clinical value? What is the standard guideline for imaging in specific CHD cases? So how do we need to build exam cards? What are standard exam cards? What is the standard resolution that needs to be done? So all this needs to be established and is not there yet, which is needed for a clinical standard. So right now, people know each other and they spread this knowledge, but we need to get this somehow organized in a better way. And I also think that the application of SmartSync needs to be easier and more reliable for fetal motion, and especially for difficult fetal positions.
Okay, and now we have another poll for you, where we would like to know what challenges do you see that need to overcome it to establish fetal CMR as a clinical standard. And I will share that with you right now. That would be very interesting, and I think for all of us, very interesting feedback.
So I think you can have multiple answers, right?
Yes, you can have multiple answers here, yeah. I will give you 1 or 2 minutes. And next to that, we have a question from Terry Cool. Terry, I would give you the possibility to talk. Can you?
I think you need to do it here. Okay. Oh.
Can you hear us? Or can you talk, Terry?
No, he has muted himself.
Ah, yeah, you are muted. We have activated you to talk now. So if you want to raise your question, you are very happy to do so right now. If not now, we just do that later, no problem. Are the results still changing, or?
Yeah, a little bit. I have 42 responses. It's very interesting that 20% has, it is a missing guideline for fetal CMR.
That the highest vote right now, followed by image quality, which has 19% right now. The next one is 15% the usability of SmartSync, including the signal instability. That's our part. We need to improve that, and we are on that. Okay, and the rest is not that often. Okay, thank you for participating. That's very, very interesting for us.
I think this is something that we can also move to some workshops to understand this a little bit better.
Yeah.
Okay. Then we move on. For what developments are coming next, we want to develop a remote solution for online support, that we can get direct access to the MR software for easier support. That is something there are solutions out there, and we're going to play around with this, and hopefully we can present something within this year. Then we're developing a larger transducer with a wider acoustic window. We have a first prototype that we validate right now. We don't know exactly how good it is right now, but we hope to have something final end of this year. This will help with the fetal movement and signal stability. Then we want to improve the algorithm for fetal heart rate detection. We already have a slider, so it helps with the depth selection. So right now we can use that if there's a placenta or something to increase the ultrasound signal. But what we still need to do, we need to automate this selection, that the algorithm is not manual in this kind of sense. We hope that we can have this as a solution end of this year. And then we have developed a data recorder tool, which basically enables everyone to have access to the raw ultrasound signal that is stored on a computer. So we have an optical cable that enables this storage. And we are currently already working with some partners like in Amsterdam UMC on the 40 Flow project, or also with King's College, to use this kind of ultrasound signals for motion compensation, to enhance sequence acquisition, to take into account this kind of motion. And then I speed a little bit up. What is coming next? So we have started with fetal CMR, of course, with our sensor, with SmartSync, but we all know that it's a kind of a niche application within fetal MR. And what we want to do is we want to offer a software solution for fetal MR that supports the diagnosis and decision making for not only cardiac but also for brain, thorax, for example, like for lung segmentations, but also for fetal weight, for example. The first version will be based on the slice to volume reconstruction from King's College London. And we already have a prototype that is available for free right now. But the version that we're developing now works a little bit more elegant. It works in the way that you send MR data to a cloud server from your PACS. On the cloud server, everything is computed automatically and processed and then sent back to the PACS system, where it's integrated into the same patient file. So you don't need to do anything else than send this to the cloud server. And then there will be a cloud software with a patient database where all the results are shown. You will have a patient history where you can see the development of this quantitative measurements. And there will be a lot of research features and new features that we want to integrate to help you for your research for fetal MR. So our goal is basically to develop a software for fetal MR. For example, in ultrasound, there's a lot of quantitative measurements possible, but in MR, there is no reporting, there is no software for your quantitative imaging, and we want to change that. So basically, we want to start with the brain imaging. Then we want to do the fetal weight calculation, and afterwards, we aim for a lung volume segmentation. This is currently our roadmap. It might change in the order. I don't know exactly if we can move fetal weight before brain or how we do that right now. But right now, this is the plan, and we hope that already next year we have the brain solution as a certified product, and in 27 the fetal weight calculation, and afterwards a lung volume segmentation. If you're interested in that, please reach out to us. All of this is already available on our prototype version on our website. So please reach out and you can use it for free. At the end, you will just select each application by choosing a simple DICOM node, and all of this will be then sent automatically. And I don't know if you have still questions. We might move them to the end if you have some, and we are very happy to answer them, because this is very important for us. What do you think about all of this?
All right. If there are no questions right now, I think we jump now over to Lorna. Or did I miss anything? Did you see? Lorna, you have changed. You have already shared your slides. This is perfect. So now we heard some ideas and future ideas, what the direction might go into. And we now want to talk to or to listen to Lorna Brown from Children's Hospital Colorado from Denver. And yeah, Lorna now shows us how this, how fetal cardiac MRI is really in the real application used, and shows a little or one clinical nice case for us. Thank you, Lorna. I hand over to you.
Thank you. So, we get a lot of requests to help people start with fetal cardiac MRI, as Fabian, I don't know. And so to address this, in our meeting in October, we have a special sessions that are completely dedicated to fetal cardiac MRI, and that is going to include 2 recorded fetal cardiac MRI scans, as well as things about post-processing and interpretation. So really especially dedicated to helping people start fetal cardiac MRI from scratch, and hopefully it'll be very technically applicable and very useful for people. So this is just a little advert for that. So we have been doing fetal cardiac MRI since 2019, and it's been part of our clinical care pathway since 2021. And I'm going to show you just a case that was from last week. We do, 1 to 4 fetal cardiac MRIs a week, and so we have a decent amount of experience in it. This is an example of a patient who we did a fetal cardiac MRI at 31-week gestation. She originally presented at 23 weeks to our centre with the concern for cardiac disease. And the concern was for double outlet right ventricle and coarctation of the aorta. On her fetal ultrasound, she was also noticed to have multiple other anomalies, including ventriculomegaly, and they couldn't see the corpus callosum. And they noticed that one of the ears was very abnormal. Now, she had some degree of a workup, but she hadn't had, sorry, that went too far. She hadn't had whole exome sequencing. So there was a concern for a genetic anomaly, and particularly the concern for the combination of the ear anomalies and the cardiac anomalies was that it was Goldenhar syndrome. And I've just put a picture of Goldenhar syndrome on this slide. And these patients, it's also known as hemifacial microsomia. So one side of the face, particularly the mandible, maxilla, and ear, are very abnormal and very small. It requires extensive reconstruction over many years after birth to try to address some of these facial problems. And so this mom was referred for fetal cardiac MRI to look at both the fetal heart and the fetal neuro to really try to understand what exactly was going on and try to be a bit more firmer with our diagnoses and outcomes. So we do most of our fetal cardiac MRIs at 3 Tesla, and this is our protocol for fetal cardiac MRIs. And I just want to show the sequences that I have here highlighted in bold. We always do some neuroimaging with our fetal cardiac MRI, just because some of these patients do have actually some unsuspected significant neurological malformations. And so we like to just have a quick look at that while the patient is in the MRI scanner, just in case. So this is the segmentation from our 3D BFE sequence. This is a sequence that we use for gathering fetal weight. We're working with Northh Medical on making this part of the prototype. And then we segment this sequence to try to get really good details of the fetal anatomy, so fetal morphology. This is a fairly high resolution version of this. It still only takes about 13 seconds to acquire. It's a breath hold, but you can see here the detail that we're getting of the fetal face and the fetal limbs. And this has adaptations or applications much more than fetal weight, because actually it's extremely difficult to diagnose skeletal dysplasias and fetal facial malformations on fetal MRI in 2 dimensions. And being able to see things in 3 dimensions just has massive transformative applications for fetal MRI. We feel we're getting 3Ds that are as good, if not better, than the 3Ds that they are achieving with fetal ultrasound. And certainly our MFM people are extremely happy with this. Just to show you a little bit of close-up what we see here, we see a very abnormal ear. It doesn't actually have a skin tag that we typically see with golden heart syndrome, though, but it certainly is a low set and a very abnormal ear. Additionally, the facial features, we didn't really see the kind of facial asymmetry that we would expect to see with golden heart syndrome. The face itself looked quite symmetric and didn't appear to have any microsomia. So this is the reconstruction of the SVR of the chest. So you can see my cursor just going over the ascending aorta. And as you follow the ascending aorta up, it gives rise to the innominate artery and left common carotid artery, but it does not give rise to the left subclavian artery or to the aortic arch. And so this is an example of interrupted aortic arch, and I'll just show you the 3D of this as well, which is nice to see. So we have the ascending aorta giving over those head neck vessels there, but not the left subclavian artery. The left subclavian artery is arising from the ductus arteriosus, and you can see there's absolutely no connection between the ascending aorta and the descending aorta. The descending aorta is completely supplied by the ductus arteriosus. So this is a nice example of type B interruption of the aortic arch with the left subclavian artery arising from the ductal arch. We do 4D flow. We can do this because we're doing our imaging at 3T. This is more difficult to do at 1.5T, but again, that just shows you the flow in the ductal arch going into the descending aorta. We're not seeing any connection with the ascending aorta and the descending aorta, either by morphology, which is on the left, or by flow evaluation here on the right. Our cine imaging showed that there were significant abnormalities of the ventricles. The right ventricle was very large. It was certainly the apex forming ventricle. The left ventricle was short, slender. It really is quite foreshortened in relation to the cardiac apex. And the mitral valve is very small. Now, of course, we don't have guidelines for what makes a ventricle too small yet. That's something that we are working on. But within our own metrics, this ventricle and the size of the mitral valve annulus were significantly lower than we would expect at this age. And so we suspect that this ventricle is going to be too small to support a biventricular repair. The cine imaging of the aortic arch shows the ductus arteriosus, and again the head and neck branch pattern, and the no connection between the anterior arch and the anterior aorta and the descending aorta, and so really also supported the interruption. You can see there the nice main stem and bilateral the trachea, the main stem bronchi in that image also. So this is an example of the 3D from the NeuroSVR and the 3D reformat, and it was very easy to say with 100% certainty this patient had no corpus callosum. That actually can be a challenging diagnosis to make in a patient whose ventricles are a little bit on the big side, because when the ventricles get blown out, it's very difficult to see the corpus callosum in 2 dimensions. So having a 3-dimensional evaluation and seeing those sulci go all the way down, we can really say that this is complete agenesis of corpus callosum. We also thought there was some heterotopia of the grey matter. Now I'm going to show you working through this. This is the inner ear. The only really way to see the inner ear of the babies and fetuses is with this 3D SVR. And we really have, I think, almost unprecedented evaluation of the cochlea and semicircular canals in this fetus. We were even able to see the cranial nerves going into the inner auditory canal. So what we were able to say in this patient was this patient has actually no external auditory canal on the side of that small ear. They did have well-formed cochlea and semicircular canals on that side, and that's important for hearing prognosis. But on the other side, actually, so the side of the good ear, they actually had some malformations of the semicircular canal. There's a very globular semicircular canal on that side. So actually, there's bilateral ear anomalies in this patient. Inner ear on the right, and then abnormal on the auditory canal on the left. We also were able to see we didn't see any facial anomalies also in on that too. So what did the fetal MRI add to this? Well, this didn't really seem consistent with golden hour. And we're actually wondering, is this charge syndrome? So slightly different prognosis and counselling with that. We did find renal anomalies as well in this patient. They had a uropelvic junction obstruction. And we were able to be absolutely certain this patient has complete agenesis of corpus callosum and bilateral ear abnormalities. And again, that's very helpful for counselling. We're also able to say this is definitely an interrupted aortic arch. I think we're able to suggest that the mitral valve and left ventricle might be too small to facilitate a biventricular repair. And so given the strong indication this baby has an underlying genetic abnormality, this baby may not be suitable for single ventricle palliation. And so this really helped guide the counselling to include, information about that this may not have the, the outcome that these parents want, and just allow them to start preparing for all the possibilities that they might be encountering in the perinatal and immediate postnatal period, and enable them to have the support system so that they can prepare for what's going to happen at that time. So I just want to finish up. Yeah.
Excuse me, Lorna, maybe I interrupt you now because there was a question that was just referring to the images you have shown before from Eva Grohmann, that the LV and the MV are too small. That was what you were saying, was not clear for Eva. Could you go back to those pictures and maybe explain a little bit more what you meant? Okay, thank you.
Sure. Well, we take a lot of pictures in a lot of different planes, and we actually do volumetrics of them. So we do a short axis stack. I think that we don't know if these are too small. I think that's absolutely right. This is what we need to try and find out from our metrics. You can't really tell subjectively if something is the right size or too small. And so we're working on actually calculating volumes and sizes of the mitral valve and trying to then follow these patients up. It's a prospective study to try to understand what makes a ventricle too small by fetal cardiac MRI. We have noticed that certainly our echo measurements are not well correlating with postnatal ventricular sizes. By fetal cardiac MRI, certainly our fetal cardiac MRI ventricular measurements are better correlates with the postnatal outcome. We have yet to really finish this study. We do not know yet what the results are. So all we can do is, from our anecdotal experience, based on we've done quite a lot of patients at this stage, but it's still just anecdotal. We don't have definite numbers that'll say this is a sufficient size ventricle, this is a sufficient size mitral valve annulus. But based on sort of our anecdotal experience of other patients with the same size ventricle and mitral valve annulus at this stage, those patients have not been able to have a biventricular repair in our centre. Now, that's a whole different, a talk on what makes a biventricular repair postnatally, and that's also very common. There's a lot of things that go into it. The aortic annulus is also quite small in this patient, so we can only, suggest that we're worried about this ventricle, and we'll have to look at it postnatally. We've certainly told this mom this baby's going to need a postnatal MRI to see if a biventricular repair is possible. But I think it's important to at least give the mom the suggestion at the moment that we don't know what's going to happen after birth of this baby, and all options are still on the table, so that they can fully prepare themselves. Because if they just think that this baby's going to have an interrupted aortic arch repair and there's not going to be any potential problems, then they may get a really bad shock in the postnatal period when they're told that this baby only benefit from single ventricle palliation, and in fact that may not even be possible because this baby has got such a genetic abnormality that the outcomes may be not good enough to be able to put that baby through that. So it's really about information, and there's still a lot of information that we need to gather. We just don't know what is the correct sizes at this point to facilitate a biventricular repair.
Very nice.
Do we do serial echoes too? Yeah, this baby mom will have one more echo. This is at 31 weeks. His mom will have one more echo at 35 weeks. But we are you know, we're learning that the fetal cardiac MRI is actually more reliable for fetal cardiac volumes, ventricular volumes, and cardiac output than our fetal echo. But you can't underestimate the benefit of being able to see a trend of things. We also use maternal hyperoxygenation, which can really help increase the size of ventricle. So there's a lot that's going into ventricular sizes. Too much for this presentation, but it is more to come on that.
All right. Thank you, Lorna. So that was 33rd gestational age, right? That's
31.
What you said?
31.
31. Okay. All right. Yeah. That was also another question that you see. Great. I think that shows very nicely what really the clinical value is of this additional technique. Thank you so much for this insight. But I give back to you. You wanted to. You're not finished.
Oh no, I think I more or less am. Yeah. I mean that's just really, you know, we can only really suggest that we're concerned about the ventricles and the mitral valve annulus, and so we. Do we comment on measurement error given the small size of ventricle that came up? Yeah, absolutely. So, I mean, this is really much a collaborative report that we do. You know, we're in and out of the fetal echo room and talking back and forwards and with the surgeons. Yeah, there's absolutely measurement error. And you know, we're still gathering normative data. You know, the data we have is still very preliminary. So, you know, we're very much, this is just based on our current knowledge, and that knowledge is not sufficient yet to be making major management decisions. So this baby's absolutely going to have a postnatal MRI where the information is much more cut and dried. You know, we know outcomes a little bit better with different sizes. Our feeling is that we're actually pretty good with fetal cardiac MRI, but there absolutely is a range, and so we give that range in our reports.
One question from Stephen Miller. Can you comment on the measurement error given the small size of the fetal heart and the inherent resolution limits of MRI?
Yeah, that's kind of just what I was answering there. Sorry, Fabian.
Okay, sorry.
That wasn't clear. Yeah, we do. We give a range in our reports, and it's really important to translate that to both your surgeons and your cardiologists to realize that there, you know, like with any technique, there is a level of imprecision. So one struggle is, somebody else had a question about the need for extra cardiac information and one scan. Do we combine two, and what is your typical gestational age? So our typical gestational age is 30 plus weeks. We have done under 30 weeks when it is clinically important. And we focus on the pressing need. And so in this case, we did the heart first, and then we did the head. You can always get the body in your heart images. So I don't typically do any specific additional images of the fetal body because I feel I can see that adequately on my fetal heart images. But you can't see the fetal head well enough. So we do at least 3 sequences through the fetal head, depending on the clinical indication. So, for example, for my coarcs, I'll always do 3 planes of T2s and BTFEs through my fetal head, and then if the mom is still doing okay, I'll do some quick EPI sequences to look for any hemorrhage, and then leave it at that. That normally can be completed in about 7 minutes for the fetal head, and then it's usually about 40 to 45 minutes for the fetal heart. That includes 4D flow, our 3T BTFE, and then our cine images, and we do 2 sets of SVR.
All right.
Oh, thanks so much, Lorna.
Okay.
There are too many questions.
Too many questions. Yeah.
That's amazing. Do we still have time for one?
I'm going to address that one in my next talk, so we can maybe.
Okay, perfect, Malenka. That is the perfect overlap. No. Tim, just quickly, your regarding the lung segmentation, yes. You have seen that your question has been answered in the chat already. Cool. All right.
Thanks so much, Lorna.
Thanks so much, Lorna. Very, very interesting, your talk. Very nice insights. And with that, I quickly hand over to Malenka, because you also have a lot probably you would like to share. Thank you so much.
Okay, hopefully you can see my slides.
Yes, we can see it right now. Mm-hmm.
Okay, perfect. So I'm going to talk about pulmonary veins, because I feel we don't ever talk about them because they're really hard. And I think that's a good topic to talk about how image quality can help clinical diagnosis. So Heidi's already pointed out to everybody of this new publication, which in some ways has been really reassuring, because it confirmed one of the things that I've certainly been seeing in our clinical workflow, is that BMI matters, and it is really tricky when you get over 30 kilograms per meter squared. So we're all used to seeing beautiful pictures in all of our presentations, and if the BMI is less than 30, then that is much more likely to happen. And you can beautifully see the abnormal pulmonary venous return with a descending vein going into the hepatic vein and then back into the IVC. However, that's not always reality, and certainly we've recently had some patients that I can only describe as what fetal nightmares are made of. So at least gestation wasn't too bad, 35 weeks. BMI was above 30, which we do get very often, but then the patient was extremely anxious, very claustrophobic, and just to add it all off, had polyhydramnias. So it really was the perfect storm for disaster. And in that perfect storm of disaster, that's the sort of cine imaging we got. And there's absolutely no way that you can actually say anything about the pulmonary veins, especially as on PowerPoint, it projects even worse than on your PACS reading station. 2D flow, you could sort of imagine the 2D black blood, you could sort of imagine the pulmonary veins. We did find that it was helped by reconstructing it in 3D and using SVR on the Northh Medical platform that Fabian already mentioned, and you could see or imagine a bit more of where the pulmonary veins went into, and we did say that appears normal. Baby's yet to be born, so we're still waiting to see whether that was true. So this fetus was pretty much in the red for most of those things that we don't have any influence on. So there are things that we have influence on, like choosing the field strength, the slice thickness, flip angle, and also gestational age. But the other ones, the ones in the middle, quite often we're just being given what we have. We can negotiate patient position, and I'll come back to that. But we found that actually maternal comfort is probably more important. So we do set things up for supine, but if they do say they prefer left lateral, that's what we then let them do. And the rest, we're really at the mercy of the fetus and the mother. So, and when you think things can't really get worse, well, the reality of clinical practice shows you sometimes they can. So 35 weeks again, BMI over 30, very common with our patients, still anxious, still claustrophobic, doesn't have polyhydramnia, so that's a bonus, but it's a twin pregnancy. And the twin in question was really high up, right at mum's top. So by the time we positioned mum, was at the fringe of the magnetic field. So you can already see some of that magnetic field artifact coming into play here. So we've really struggled with the imaging because mum, being a twin pregnancy, really only tolerated a really short scan. So we didn't even get enough black blood imaging to do some SVR reconstruction. You can sort of see them there. We did a white blood transverse stack that we always do because that's sometimes a good fallback option. And we did think that the pulmonary veins were going back into what looked like the left atrium. And you can see the cine imaging, which again on your PACS platform looks a bit better. It's a bit dark on here, but again, it kind of looks like the pulmonary veins are going where they are supposed to. However, once a baby was born, baby actually had intracardiac TIA-PVD, which really prompted us to think a little bit more about our pulmonary vein imaging, and especially those intracardiac TIA-PVDs where they're sort of got in the right position, but not quite. I've really went back and thought about image quality improvement, which is partially why Heidi asked me to give this talk. So as I've already mentioned, we set things up for supine, but actually what we found is that an uncomfortable mum is probably the worst thing to have. In some ways, it's worse than a moving fetus, because an uncomfortable mum almost certainly will have a moving fetus because there's just too much agitation going on all around. So if mum says she always falls asleep on the right side or the left side and she can't lay anywhere else to get comfortable, then be it. We spend quite a bit of time just putting as much padding around mum as possible and make them feel really comfortable and relaxed, and just make sure that we get at least one smile out of them before we actually start the CMR scan, just so that they feel relaxed. Hopefully that then also relaxes the fetus. We've recently swapped things around. We now do the black blood imaging first, just because that then helps us to place the Doppler ultrasound device. In the UK, our patients don't have a regular Doppler measurements like they do in some other, like in the States. So women are not always aware of where the best position is to auscultate baby's heart. And with doing the black bloods first and then doing this in imaging, what we find is we are much quicker at placing the Doppler device, so the overall scan is shortened, and therefore the women are less uncomfortable and less stressed. Fetal movement it is really, really tricky, but I do think there's quite a bit that we can do to prevent that. So again, we spend quite a bit of time with the mums beforehand, make sure that they're feeling really, really comfortable and, you know, looked after. And we always say, you know, this is your 20 minutes, half an hour, where nobody else is going to disturb you, especially if you've got other kids. Nobody's going to go, mummy, can I have this or that? You know, we put some calming music on, and we just say best thing is to actually just nod off and go to sleep. And most women, because we do them in the evening, will have had a hectic day, and they're actually welcome to just have a bit of peace and quiet. So we just dim the lights and set the scene. I know there's a lot of discussion about whether we should breath hold or not, but our experience is when we ask them to breath hold, they are more alert, they're not relaxed, they're not going to sleep, and we end up with much more active babies than we would otherwise. So we moved away from that. We've also found that actually the breath holding is not very adequate a lot of the time, which is understandable if you're 30+ weeks pregnant, lying on your side and have a fetus pressing against your diaphragm. We've then also worked on our black blood imaging improvement, because we said we really need to get better at this. So we've reached out. So we are based on a Siemens platform, which traditionally has been a lot trickier to get good black blood imaging than seen on the Philips and the GE machines. So we reached out to Siemens, worked with them, and actually Northh Medical have done quite a bit of work on the Siemens sequences that they send out for black blood as well. And this is an image of the most recent one that Northh Medical sent us. And actually this looks really, really good. This wasn't actually meant to work for SVR, but it actually works very well for the SVR reconstruction. So we get really good black-white contrast. It's also much faster than the one we had originally. So our whole black blood imaging is now much shorter. It takes less than 10 minutes. And most importantly, we've done it for quite a few variety of body habitus and fetuses, and we actually get consistently good results now, which is really what you need for a clinical service. And similar to Lorna, we scan about 2 to 3 fetuses a week, and they're all comers in all sizes. So we need something that really works consistently. So what we do the black blood SVR in 5 directions, and we do 2 stacks because they're so nice and quick now. Put it into the fetal MRI post-processing platform on Northh, and then we either use Mimics, which has the approval, or 3D Slicer, which is free to segment the cardiac anatomy. But what about twins and the SVR? Because when you read the SVR instruction carefully, it says it can't cope with twins. It doesn't know what to do with it. But every so often we do get twins. So I've been working on trying to figure out how to make that happen. And something we had varying results with is actually to just black the other twin out. So just putting a SAPS band over the twin so it's actually not visible. And then if they're not quite as entangled as this set of twins, we actually get reasonable pictures. This set of twins was a bit more tricky. But it's also important to note that was with our old black blood. So it'll be really interesting to see how that plans out with the new black blood and see how the SVR copes with that. So far, we've always mainly thought about pulmonary vein imaging by using the SVR, but actually, especially when it comes to intracardiac, abnormal or abnormal cine imaging really is very important, because when you see that on the left there, the veins are coming in, but they are coming in a slight unusual angle, and they're a bit further apart than you would expect them to be. And then actually when you look at the cine imaging, you can see that actually they are coming into a confluence behind the atrium, but then freely draining into them. So it is really important, especially for the intracardiac, to have good cine imaging. And good cine imaging can be really, really challenging. And that's really just to show you, to go back to my very first cine imaging, because I thought I'll get it back out of the graveyard. That was in 2021 when there were no protocols yet, and we tried it on a 3T Siemens, just some standard images that we use for our neonatal MRI. And as you can see, it was a complete disaster. And so don't be disheartened if your cine imaging doesn't work straight away. It takes time. And I think there are a lot of different approaches. So one of the things we're currently trying to do is to standardize approaches and come up with protocols that fits most scanners and most centres. Our approach is to scan as fast as possible, not to use a breath hold, maximize coil coverage. That's really helped. We've played about with image filters. That helped as well, especially in the Siemens platform, because we're then mimicking a bit more what goes on the GE and Philips platform. And deep learning algorithms, I think, becoming more and more prevalent on all three vendors. And then somebody very clever told me, just keep repeating it until you get there. And so the reason we scan as fast as possible is that even with the best intention in the world, fetuses move. And so we find that if they're like 7 or 8 seconds, it's just too long. So we tried to keep our cine imaging at 2 to 3 seconds. And that was a 3-second acquisition. So, you know, if baby moves during that, even then you get movement. But then if you keep repeating it, eventually you get one, but baby stays nice and still. We do a non-breath hold, and actually when you can see breathing motion from both mum and the fetus on this picture, but actually it doesn't seem to influence the cardiac images as much, because again, when scanned fast enough, that actually the breathing motion doesn't seem to interrupt the image quality of cardiac quite so much. And we find that mums are just calmer. We've really played about quite a bit with coil coverage recently and feel that that's really made a huge difference, both in slim and in larger ladies. So we now built a little tent with 2 sets of coils, and we have actually just purchased the ink space coils, which are beautiful wraparounds, as you can see here on the back. So we're going to put 2 next to each other to kind of wrap around the tummy to increase maternal comfort and coil coverage as well. And then there's definitely a place for deep resolve. I think there's no question, and I think everybody knows that. And it will hopefully help us just give that little bit of extra. I know GE's already got it inbuilt in some of their most recent cine imaging, and they look absolutely stunning. Philips is doing it as well. So Siemens is trying to catch up there as well. And Jen, just at the end, I was going to show 2 interesting cases where MRI really helped in terms of pulmonary veins. So both of them were antenatally diagnosed with hyperplast left heart, and there were some concerns about the pulmonary venous drainage. So in this one, there was only one seen on echo draining to the IVC RA junction, and we saw exactly the same thing on fetal MRI, but we also saw this additional arterial feeding vessel that hadn't been quite so much noticed on the fetal echo coming from the descending aorta. And most importantly, when we looked at lung volume, was that there was a very clear difference with a very small right lung, which was only half of what was expected, suggesting that there really was very, very abnormal right pulmonary venous drainage, but also an additional arterial feeding vessel into the descending aorta. And this was confirmed postnatally with a CT, and patient was then declined for a Norwood procedure based on this. And the case 2, again, was somebody with hyperplast left heart and a very restricted septum, but on fetal echo looked like there may be decompressing veins. So we did a fetal MRI, and really interesting what we found was that actually the left middle and left upper weren't returning to the left atrium. They were all very dilated vessels, but actually they went into a vertical vein that then went into the innominate vein. So what was seen on fetal echo was actually a vertical vein with some decompressing collaterals. So there was actually PA-PVD, so partially abnormal venous return, rather than a decompressing vein with very dilated pulmonary veins. So again, this baby was confirmed postnatally on echo and was declined for a single ventricle pathway. And just to raise awareness for those on this side of the pond, we're hosting our fetal cardiac MRI workshop, 30th of June, 1st of July, where experts across the world will come together, but people just starting up a fetal MRI are also more than welcome to come and join us, where a big focus will be on talking about clinical implications and standardizing clinical implications of what should be referred for fetal cardiac MRI, with the aim to then produce a consensus statement following on from this, what common cardiac fetal MRI referral implications should be.
Thank you.
Thanks so much.
Malenka, thank you. Just one question from Alex, but it has been answered already by Fabian, but I just wanted to ask whether you want to comment on that, Malenka, regarding the twins and the SVR. Alex was mentioning you can manually mask out one twin with the masking option in the SPR online tool. This is correct. Do you want to comment on that, or is that all it is to say about it?
Yeah, so I've not actually used the manual tool. So that's a really interesting information. So I've always just worked with the automatic one. But that's certainly something I'm going to reach out to Alex and ask him about it, because that would be another option of how to deal with those fetuses. When we do
Perfect.
have true.
Okay, great.
So I think what is really interesting also with what you just said, Malenka, also with the workshop you're doing with the Hazelwood workshop, but there's also the SPR course that Lorna will do in Denver. Then there will be an APC workshop in Warsaw, also on fetal cardiac MRI. And all of this guides into the direction of a guideline. And I think it is very important to use this kind of workshops to connect and to transfer knowledge and discuss what should it be, and use these workshops and meetings for this kind of opportunities, because they're coming this year. There are so many workshops on this, so we can't advertise this enough to see all the people there. So please reach out to the people, to Lorna or to Malenka to visit these workshops.
And also, as we have seen in the poll, one last comment, there are about 12 participants of this webinar that have not yet any experience regarding fetal cardiac MRI. You can always reach out to us for help, for support, for whatever you have for questions, and we are very happy to support you with anything we can. Do you want to say anything at the end, Fabian? Or
to the guys that said the image quality is one of the biggest issue. These have also been 20%. Please reach out to us. I think Domenico has done a lot of amazing work on exam card optimization. We would really love to give that to you, so that we can handle this kind of issue. From our knowledge so far, this was really successful. So please really reach out to us that we can help with that.
Right. And with that, we are already at the end of our spring session webinar. We'd like to thank, of course, all our participants that have been here today, all our supporters. Really very much thank the Fetal Heart Society and the CMR for support, and of course Malenka and Lorna and Fabian for talking today and giving us very nice insights into the world of fetal cardiac MRI. We'd love to see you again to our summer session, which is already in 2 months, in June 25th, and I will update you with all information regarding that as soon as possible. Thank you so much. Have a great
much, everyone.
day, evening, whatever. Bye-bye.